Now that we have provided a high-level overview of the reportable STIs, let's take a look at screening recommendations. In this lesson, we will learn about the screening recommendations for chlamydia, gonorrhea, syphilis, and HIV. Since most females are asymptomatic when infected with chlamydia and gonorrhea, the recommendation is to provide annual screening in sexually active persons with a cervix to those under the age of 25. Think back to the data on STI rates by age. We prioritize persons under 25 because that is where we see the highest rates of infection. Providers may also screen persons over the age of 25 if they report having new or multiple partners or are known to be linked to a case. Females are more likely to have concurrent infections, where if they are positive at the rectum, they are also positive at the genital site. So the data on multi-site testing is not as strong as it is for men who have sex with men. However, the screening recommendations do indicate that multi-site testing can be considered through shared decision-making with the patient and provider in women with extragenital exposure. Any person who tests positive for chlamydia and/or gonorrhea should be retested for reinfection in 3 months. All pregnant persons who are either under the age of 25 or at increased risk should be tested for chlamydia and gonorrhea at their first prenatal visit. Persons who are positive should be retested during the 3rd trimester if they are under the age of 25 or at increased risk. If positive for chlamydia, persons who are pregnant should receive a test of cure 4 weeks after treatment and be retested in 3 months. Men who have sex with women, chlamydia screening can be considered in high prevalence clinical settings like adolescent clinics, correctional facilities, and STI sexual health clinics, but there is insufficient evidence for screening asymptomatic heterosexual men who are at low risk for infection. Sexually active men who have sex with men should be screened annually at all sites of exposure. If at increased risk, more frequent screening every 3 to 6 months should be considered. And finally, persons infected with HIV should be screened for chlamydia and gonorrhea at their first HIV evaluation and annually thereafter. More frequent screening can be considered based on risk and local epidata. The screening recommendations for syphilis are a little different than the recommendations for chlamydia and gonorrhea. Syphilis, though on the rise, is much less common, and the majority of cases are reported in men. Though syphilis infections are characterized by symptomatic stages, the symptoms can easily go unnoticed, particularly for receptive partners. CDC recommends screening sexually active women with symptoms or persons at high risk of acquiring the disease, which they define as history of incarceration, transactional sex work, geography, and race and ethnicity. CDC recommends screening all pregnant persons in the first prenatal visit. Nationally, the recommendation is to retest at 28 weeks gestation and at delivery if they live in a community with high transmission rates or if they are at risk for syphilis acquisition during pregnancy, such as persons who report substance use, STI history, multiple partners, a new partner, or a partner with an STI. This slide shows what is required in Arizona. In Arizona, all pregnant women are required to receive syphilis testing in the first prenatal visit, early in the 3rd trimester, and again at delivery, as outlined in the Arizona Revised Statute and the Arizona Administrative Code. More and more states are implementing laws to require screening at the 3rd trimester and at delivery due to the nationwide rise in congenital syphilis. The CDC recommends only screening men who have sex with women if they are at increased risk. In Arizona, we also recommend screening the partners of pregnant persons. Sexually active men who have sex with men should receive at least annual syphilis screening. More frequent screening may be recommended if at increased risk. CDC recommends offering annual syphilis screening for transgender and gender diverse people based on reported sexual behaviors and exposure. And sexually active persons with HIV should receive syphilis screening at their first HIV evaluation and at least annually thereafter. More frequent screening might be appropriate depending on individual behaviors and local epi-data. The screening recommendations for HIV are a little different than the recommendations for chlamydia, gonorrhea, and syphilis. The 2006 CDC recommendations state opt-out HIV testing is recommended for all women between the ages of 13 and 64, regardless of risk. Opt-out testing is when a patient is informed that a routine screening is to be performed and they're given the option to decline. This approach to HIV screening removes stigma, fosters earlier diagnosis and treatment, reduces risk of transmission, and is cost-effective. It is recommended that all women who seek treatment and evaluation of any STI also be screened for HIV. CDC recommends opt-out screening all pregnant persons in the first prenatal visit. Persons should be retested at 28 weeks gestation if they live in a community with high transmission rates or if they are at risk for HIV acquisition during pregnancy, such as persons who report substance use, STI history, multiple partners, a new partner, or a partner with HIV. Rapid HIV screening is also recommended at delivery for persons who were not screened during pregnancy. Opt-out HIV screening is recommended for all men between the ages of 13 and 64, regardless of risk. It is recommended that all men who seek treatment and evaluation of any STI also be screened for HIV. Sexually active men who have sex with men should receive HIV screening at least annually if their status is negative or unknown, and the patient or their sex partner or partners have had more than one sex partner since the most recent HIV test. More frequent screening may be recommended if at increased risk. The CDC recommends offering HIV screening to transgender and gender diverse people. More frequent screening may be recommended if at increased risk. In this lesson, we explained that persons with a cervix, men who have sex with men, transgender and gender diverse persons, and persons who are HIV positive are key populations to prioritize for STI screening. Due to the prevalence and asymptomatic nature of chlamydia and gonorrhea, annual screening is recommended for all sexually active persons with a cervix under the age of 25. STI screening, including screening for syphilis, is also important for pregnant women. In Arizona, providers are required to offer syphilis screening at the first prenatal visit, early in the third trimester, and again at delivery. There is less evidence to support routine screening in asymptomatic men who have sex with women, though screening can be considered in settings with high prevalence, like adolescent health centers, correctional facilities, and sexual health clinics. Due to the disparity of STIs among gay, bisexual, and other men who report male sex partners, annual screening for syphilis and annual site-specific screening for chlamydia and gonorrhea is recommended for sexually active men who have sex with men. Since there is a high prevalence of HIV-STI co-infections, at least annual screening for STIs is recommended for persons living with HIV.